Dear colleagues, dear chairs, I would like to thank All India Ophthalmological Society, especially Dr. Feroz, my dear friend, for the kind invitation. Here we are going to have a deeper look into the outcome of any ptosis surgery beyond the MRD1. No financial disclosure. Have a look at this picture. What we see is the eyelid ptosis mostly, and we do and measure how far we can correct this eyelid ptosis from this to this. Of course, this is our main outcome, but how about the other things like eyelash ptosis the patients are coming and complaining of? This could be an outcome in my observation. People are complaining of that. Is it getting improved like this? And how many and how? We don't know. How about the associated lower eyelid scleral show, as you see in here? Some people are coming and complaining of that. Is it getting improved? How far and how? We don't know. That could be like this, getting improved completely or not. And the last but not the least is how we have the levator function changed post-operatively. And how can be this one implemented in our clinical practice of redo procedures? That's why the outcomes, to me, they are divided into primary and overlooked secondary outcome, including eyelash ptosis, lower eyelid scleral show, as well as the levator function check. We did a study on these overlooked outcomes. Here I am going to present two of them, I mean the eyelash ptosis and lower eyelid scleral show, comparing the unilateral simple myogenic ptosis with unilateral aponeurotic ptosis, serving the other normal eye as a control group. All of those three studies have been recently published, and you can have access on PubMed or anywhere else. We graded the eyelash ptosis from 0, which is normal, to 3, the most severe one, based on Malik's classification. An associated scleral show was shown in our study as MRD2. We found preoperatively 50% of patients with myogenic ptosis. We had 58 cases in this group and 20 cases in the aponeurotic group. 50% of them had the grade 2 or 3, the moderate and severe type of eyelash ptosis, whereas 25% of aponeurotic group showed the same severity of eyelash ptosis, meaning that myogenic ptosis group are having more severe and more frequent ptosis, eyelash ptosis, than the aponeurotic group. When we did a correlation study, the lower levator function and more severe ptosis were significantly correlated with more severe eyelash ptosis. The eyelash ptosis got improved by 1 grade or more in more than 80% of both groups. However, more than 50% of the myogenic and 30% of the aponeurotic group remained with some degree of eyelash ptosis post-operatively. How about the scleral show? As you see here, the myogenic ptosis showed less severe in terms of mean scleral show comparing the ptotic side to the fellow eye. The myogenic group showed less severe than the aponeurotic with 0.8 millimeter scleral show preoperatively, and less frequent, 60% of the myogenic, whereas 80% of the aponeurotic group were showing the scleral show preoperatively. And post-operatively, similarly, the myogenic group ended up with less, remained basically a scleral show in just almost 9% of their cases, whereas 20% of aponeurotic group ended up with residual scleral show. The success of lower eyelid retraction or a scleral show after ptosis surgery, if it is defined of getting improved by 0.1 millimeter and more, was more than 90% in both groups. Here are some examples. Lash ptosis of 3 getting corrected to 0 after levator resection, and a scleral show of 7 getting improved 1 millimeter to be closer but still remain the scleral show on the ptosis side. This case, however, is having lash ptosis of 3 totally improved, as well as a scleral show as compared to this one 4-5, now becoming 4-4 in both group, both eyelids. Lash ptosis of 1 is getting improved to 0, and MRD tune of 7 is getting 5.5, which is almost the same as the other eye. Lash ptosis, there is nothing preoperatively, remain the same. MRD2, however, getting 1 millimeter improved to somehow reach to the same as the normal side. And lastly, lash ptosis of 1 getting same postoperatively. MRD2, however, getting improved by 1.5 millimeter. Here we see the difference. Here we see no difference between the two eyelids. In conclusion, myogenic ptosis, when we are dealing with that, they have more severe and more frequent eyelash ptosis that should be considered than aponeurotic ptosis, pre and postoperatively, residual one I mean. On the other hand, aponeurotic ptosis showed more severe and frequent lower eyelid scleral show than myogenic pre and post-operatively. We have 50% of myogenic and 30% of aponeurotic group remaining with some degree of eyelash ptosis, and 9% of myogenic, whereas 20% of aponeurotic are remaining with some degree of a scleral show. How could those be implemented into our practice? Whenever we see a patient with a ptosis and higher grades or more severe grades of eyelash ptosis, we might consider beyond the levator resection to go for either tighter and deeper crease formation, anterior lamellar reposition, or gray line split to decrease the severity and frequency of remaining eyelash ptosis postoperatively. And we need to remember answering the question, usually coming from the patient, how about my lower lid scleral show? The answer is you don't need any lower eyelid surgery before the levator surgery is done, because most of these scleral shows are getting improved. Any remaining one could be addressed later on. And thank you very much for your attention.